This is the advanced airway algorithm um, to help you kind of figure out how to manage your patient with advanced airway. So anything more than an OPA or MPA is going to be considered an advanced airway. So the need for intubation or an advanced airway management is identified by insufficient oxygenation or ventilation and unable to manage with other means. So first thing you're going to do is apply the oxygen via nasal cannula at a flush rate 15 liters per minute. This cannula stays on until airway is established. So kind of a couple of reasons. One, this is an attempt to generate some kind of passive PEEP, and it kind of helps pre-oxygenate your patient. Then you're also going to pre-oxygenate your patient with either a non-rebreather, a BVM, or some non-invasive positive pressure ventilation like CPAP or BiPAP. You want to optimize positioning, so sniffing position, elevate head to sternal notch. All right, then you're your equipment ready. So you need to have suction, a bougie, any intubation equipment you have. So if you want to go with the camera first, have your camera, have a backup device ready. So if you're going with the camera, you want to have a direct laryngoscopy device ready. So direct laryngoscope. And then you also need to have a cart kit available. Then you need to ready your personnel. So the person managing the airway, and then you also need to have an assistant who is not busy doing other tasks. If unsuccessful, optimize the next attempt by changing the patient position, technique, equipment, or provider. So if you don't get it first time with direct laryngoscopy, try the camera, vice versa. You might try having a different, if there's more than one provider on scene capable of managing the airway, you might do that. You may try instead to use a iGel instead of intubating. If successful at any point, proceed to post-intubation care. So here's kind of the algorithm we're going to follow. If your SpO2 is greater than 93, you go to the green side, and then we'll follow that on down. So oxygenation is okay. Proceed with airway attempt intubation or BiAD, so iGel. Halt attempt when SpO2 is less than 93. BVM with adjunct and PEEP valve. Can you reoxygenate with BVM to 93%? If yes, assess for reasons that attempt failed. Make changes to optimize the next attempt and repeat attempt. All right, so if you could not reoxygenate your patient to 93%, you go down kind of from where the green meets the middle, kind of in the middle there, and it says no, can't reoxygenate. Place BiAD or backup airway. And same thing over here, assess for reasons that attempt failed, and if you can't make changes, then you just go ahead and place a BiAD. So at the top, we'll go back to the top. If you can't oxygenate above 93%, this is a suboptimal oxygen. It's a danger zone. Just place the fastest airway. So first thing you're going to do is insert a BiAD, so an iGel. If it's unsuccessful, BVM with an adjunct and PEEP valve. Can you reoxygenate with BVM back to pre-oxygenation level, a minimum 80%? If yes, you keep going down in the yellow, assess for reasons that the BiAD failed, and make changes to optimize the next attempt. If you can make changes, you repeat attempt, and then go back up to BVM with adjunct if it's unsuccessful. If you're bagging with a BVM after an unsuccessful attempt at inserting a BiAD, and you can't reoxygenate or the patient becomes unstable, one provider can attempt a crash oral intubation, and a second provider proceeds with a cricothyrotomy if the intubation is unsuccessful. And same thing for if you can't make any changes to the BiAD attempt. Now, the bottom of the protocol thinks it's important to note that this notes the level of severity, not the provider level like it does in the protocols. So green is less severe, yellow is medium, and red is critical.